right? So continuing on with pediatric section, we have Stephen George, who will give us the talk on new technologies in pediatric deformity.
Thanks a lot, Lionel. Thank you guys for allowing me to talk to you today about navigation in pediatric spine surgery. This talk actually dovetails what Dr. Birch talked about. I do 100% pediatrics, so this talk also goes into a little bit of my experience and sort of adapting my practice to accommodate for some of this new technology. And the question is it really a crutch or is it really critical? No relevant disclosures for this talk. And again, I'll go through some of this early stuff pretty quickly because it was mentioned previously. But when we talk about the history of navigation, I mean, it's really evolved from this stereotaxis or localization using a 3D Cartesian coordinate system, you know, pioneered by the neurosurgeons in the 40s, but then in the 80s used for frameless biopsy technology. And then in the early 90s, there's some studies published on frameless stereotaxis with insertion of lumbar pedicle screws. You know, one of the things we really see as we go through historically, obviously, is that, you know, more recently there's been just a lot more research and publications on this as we've learned a lot more about its utilization. But, you know, what we see, though, is that a lot of it has to do with pedicle screws, and we'll get more into that later on and how that's just, you know, scratches the surface of what we really need this technology for. You know, when we think about registration in spine surgery, the fundamental principle is that you're merging an image, either preoperatively or intraoperatively, to a real point on the patient, and then utilizing a fixed reference that's secured on the patient. And this can be accomplished in many different ways, using fiducials with camera-based technology or fluoroscopy or just simply fiducial-based technology on the patient or on the scanner. You know, and we look at some of the early literature in pediatric deformity, and again, this looks at a retrospective cohort, and it shows that the accuracy of screw placement utilizing this navigation is quite high, you know, at 96%. And then when you look further at where the inaccuracies came, it's as we expect in these smaller pedicles up in the upper thoracic region, where it seemed as though it would have the, you know, some of the higher risk pedicles are located, and that's where they found that some of the inaccuracies came. And then when you look at some meta-analysis on several modalities of pedicle screw placement, whether it's fluoro or CT, robot, or 3D guided, what it shows is that they all have lower complication rate than freehand alone. Now, with that said, we have to look further into the data because all modalities have actually a relatively low complication rate, even just freehand alone, but they did show some small improvements with adaptive technologies. But freehand, again, is still very safe. And then when you look at pedicle screw accuracy, and in this paper, they looked at CT navigation versus freehand and 2D fluoroscopic assistance. And in their set, they found it was 3 times more likely to be deemed acceptable if with a 3D navigation, and twice as likely to be perfect. And a third of the time was less likely to be potentially unsafe. And again, you're talking about a very small number of unsafe screws and clinically relevant mistakes that happen in any of these groups. When we talk about return to the OR, navigation versus freehand fluoro technique, this paper looks at 105 navigated patients versus 112 with fluoroscopic guidance. And when they looked further into these patients, they found that 4 out of the 112 fluoroscopic guidance had to be returned to the OR for a malpositioned screw, while none in the navigated group had to do so. And drilling down a little bit more into this population, they said they saw that 51 patients underwent a CT scan for some other reason, not from the surgery, but taking that data and looking at the screws, they saw that 206 of the, they visualized 526 screws. And of that, they saw that there was a higher malposition rate with the fluoro group versus the navigated group. Again, not clinically relevant, but just showing that there was a difference in accuracy. Getting into a little bit about my experience with the technology, I was under, I did everything freehand early in practice, and I really thought to myself, if it ain't broke, don't fix it. And if navigation was only going to help with placement of standard pedicle screws, how would that really impact patient care? One of the things that we all talk about is having a good surgical team and a good workflow and a good technique, is paramount to a lot of the other nuances of technology. So it really pushed me away from adopting very early. And I really didn't see the significant outcomes benefit with the technology. However, there was a shift that occurred. I would say that I was more willing to know that, my workflow could be adapted. And it was more than just placing pedicle screws, and that my patients could probably benefit from this. So I really started to explore what would be that use, or what would be the indication in my practice. And again, my practice is 100% pediatric deformity. Would it improve my safety profile? Would it slow down the workflow so much that it would also cause harm to the patient? Would it really improve my accuracy in a clinical way? And was it worth the cost? And what was the feasibility of that? In my current state, I utilize it a lot for teaching, a lot for my complex cases, whether it's congenital scoli, high-grade spondies, complex revision where you have really distorted anatomy, any patient with significant anatomic anomalies. And you can use this for just about anything, whether it's with or without traction, which we do on some of our bigger deformities. And it can be used in posterior and anterior surgery. So I wanted to go through just a few cases and continue to ask the question, is navigation a crutch or is it critical? And all these cases, what I would say is that they could be done without navigation. They really could. But when you look into your own practice, the question is, what would utilization of this technology do, or how would it benefit your patient? So the first case here, we have a 16-year-old female who presented for a third opinion on a progressive kyphotic deformity. She was diagnosed in an outside hospital with progressive Scheuermann's, and 2 years ago, 2 years prior to presentation, was scheduled for a posterior spinal fusion. During her pre-op eval at the outside hospital, an arachnoid cyst was identified extending from T9 to L3. Here are some of the initial MRIs showing that cyst. And at that time, the deformity surgery was put on hold, and neurosurgery took over, and they resected that cyst through a T9 to L3 laminoplasty. However, subsequent to that, the postoperative course was not pertinent, except for the fact that there was a worsening kyphotic deformity. And as that deformity got worse, he went back to those surgeons and said, okay, well, how do I correct this? And they then said, well, things have changed a little bit because no longer can we do this posterior, but now we need to do this sort of an anterior-posterior procedure because of, the distorted anatomy and the rigid deformity. So she was a little disappointed by that. She is a 11th grader, and she's a twin. They both enjoyed sports. And the idea of going through a posterior surgery was bad enough. Then she had this other diagnosis. Now they're telling her that she'll need both an anterior and posterior surgery on top of that, which was, a little disappointing to her and the family. So here we have recurrent radiographs. It's a 96-degree rigid deformity. And then when we look at some of the CT scans, we see these very dysplastic pedicles. We see the dural ectasia, and we start to understand why the surgeons at the outside hospital were telling her that, well, in order to correct this, we probably won't get good enough fixation posteriorly, so this is something we might have to deal with anterior posterior. So obviously there's several approaches for treatment of this, and the question is there a space for navigation here? Is it necessary? How will it change the way we can treat this patient specifically? So some of the considerations: we do have a rigid kyphosis, we've got really sclerotic and dysplastic pedicles in a real critical area of the deformity, and you have very poor distal fixation with absent posterior elements all the way down to L3. So the plan for this was just to attempt posterior only, using Ponte osteotomies and the navigation, and hopefully just using pedicle screws and sublaminar bands for fixation. If the fixation was insufficient, we obviously would go anterior as well. And here's just some intraoperative pictures here showing us sort of using navigation to really identify these really thin pedicles, but also cannulate them. And some of the findings were just as what we thought. Some of the things that we were really surprised about and very happy to see is that we were able to get good pedicle screw fixation, and that was on the first try. And as many of you know, when you start placing pedicle screws in suboptimal pedicles, you can get it, and sometimes it's not the first try or second try, but maybe the third try. And then you have to be honest with yourself. Okay, I have the screw in there now on the third try, but what can I do with it? It's there, but can you really do much with that anchor point? And I would say that oftentimes it's not the case that you can do much. But so getting it on the first try, predictably, was critical. And here we are. Here's her first direct at 3 days post-op. Braced her for 3 months. Now she's 3 years out. She's back to all activities, and this was just posterior only. Again, the question is, do you need navigation for a case like this? Perhaps not. But what I can say is that there is a level of predictability and reliability that you get going into a case like this where doing it freehand would not allow you to have. So for that reason, I do think it impacts your ability to treat that patient. Moving on to another case, this is a 15-year-old female, 3-year history of bilateral lower extremity pain and back pain, previously treated conservatively with no improvement, and now this prevents her from playing sports. When we look at her standing radiographs, we see that she has this high-grade spondy, but when we look at closer, we see that it's actually she has transitional anatomy, and so she has a lumbarized S1, so it's a high-grade spondy at S1, S2. What does that really mean? I mean, I think this is different because the anatomy is now different. The nerves that we are concerned about are different, and the pelvic anatomy is now going to be very different where we can find distal fixation. Okay, so again, the goals for in this procedure, again, stop progression of the slip. We need a solid fusion, and they need safe improvement of the slip angle. From the anatomic standpoint, we see that it's S1, S2, so pelvic fixation options are going to be a little bit different in this patient because a pelvic screw, or an iliac screw rather, is not going to line up with your construct. But when we think of an S2AI option, this is not going to be useful in this patient because our fusion is going even lower than that. So how do we do this? Do we need an anterior posterior, or can we do this posterior only? And so for this patient, we go posterior only. We do L5 to the sacrum with pelvic fixation. Unfortunately, the method of fixation to the pelvis is going to be a little bit concerning because of where we are in the anatomy. But the plan is to put a TLIF in S1, S2. And then intraoperatively, obviously, for those of you who've done high-grade spondies, that slip vertebra, getting a pedicle screw in that vertebra is incredibly difficult because it's, the vertebra is well anterior, and being able to get predictably good fixation in that pedicle can be a challenge. With navigation, that's not usually the case. The S2 alar was not possible, as I mentioned before, and an iliac bolt was also not possible, even with a connector. So utilizing these image guidance, we were able to get that screw into the S1 pedicle on the first try once again. And then we were able to accurately navigate that 1-2 disc space. Sometimes when you have these domed sacrum and you're trying to get a good inner body in, it's hard to know where you are anterior as you're doing that disc prep. You can navigate that and actually do that without an issue. And then also identifying a reliable trajectory for some pelvic fixation. We were able to do what we could probably call an S3 alar iliac screw. And intraoperatively being able to find that corridor was actually quite helpful in this patient. And here she is 2 years post-op, and she's doing well. Again, it's not about showing the x-ray, but showing that intraoperatively, this was much lower stress, much more reliable, even in patients with, complicated anatomy. In this other case, this is probably a case that many of you may see even in the adult population, and this starts off with a 9-year-old female who's seen in an outside hospital and treated for scoliosis. A year after the scoliosis worsens to where she has a 53-degree left proximal thoracic curve and a 70-degree right thoracic curve at RISR 0 with hyperkyphosis. She underwent surgery at that outside hospital, going from T3 to L4. After about a year, a little less than a year after, she started complaining of neck pain and showing worsening of a neck deformity. She was found to have PJK, and then the surgeon discussed with her possible surgery at that time. She then came to see us about a year later for revision surgery, and here she is, PJK'd over the top of this construct, and the question is, what do we do now in the symptomatic patient? We get a CT scan, and we start to see that even the hardware in the proximal construct is suboptimal with these screws that have migrated into the canal, and that's at several levels up at the top. And then when we look at the Recon, we see that this deformity is relatively rigid here on that CT Recon. So what's the plan here? Again, you'd like to do as little as possible. You'd like to say, well, let's extend this up maybe just one level to help correct this. But then we also know that we've got these screws that are placed or malpositioned screws up at the top as well. And what's the reliability in being able to recannulate those pedicles at the top and be able to get enough purchase there to actually improve that deformity with such a small area? Is navigation necessary here? I don't know. We use it here, and I think here we are at 2 years. She's returned to everything, and as you see that just going up one level, we're able to really get significant improvement. Yeah, we're able to get significant improvement with her sagittal balance here. So another opportunity where I think navigation really helps, because if you could certainly do this free-handed, but if you've ever tried doing that, just getting your hand, dropping your hand to the head enough and not manipulating the anatomy to get those screws in is quite difficult and relatively unpredictable sometimes, especially when you have one shot at getting it. This last case here is a young female who came to me from Peru, and she came with a lot of back pain and was found to have pathologic fractures in her lumbar spine. And she's found to also have neurofibromatosis 1 with increasing back pain. So when I initially saw her, she had this lumbar deformity, and then as I continued to follow her, you see the deformity continues to worsen, and you say, well, what's going on here? And what actually is going on here is there's these pathologic fractures that's happening in her lumbosacral region. You can see the dural ectasia, but also the thin pedicles. And what would happen is she would move and fracture the pedicle. And that pedicle would heal, and she would fracture again, and the deformity would get worse and worse. And the question is, when do you intervene, what do you do, and how do you do it? Okay, the MRI here again shows significant dural ectasia. And what would the plan be? Again, with these patients with NF1, historically what we like to do is anterior-posterior because they have very poor bone healing properties. And even when you do them just posteriorly, they end up failing there and you have to go back. So the plan here was an anterior-posterior procedure with an ALIF at L4, L5, and L5S1, and posterior spinal fusion from T10 to the pelvis. This was also important because if you look on the CAT scan, you see that she hardly has any usable posterior elements in the lower lumbar spine. So the anterior support in her was also critical. Now, in this situation, we actually used navigation to place the instrumentation in the front of in the anterior spine. As I said, this individual is quite small, so we had to use actually cervical instrumentation just to instrument the lumbar spine. And if you look, I don't know if you can see this here, but when you have these severe deformities and you go in anteriorly, it's hard to even orient yourself to find where midline is and what trajectory you can use for a screw. You see those scalloped bodies, and even if you're putting in a screw there, that measures a little over 1 centimeter in length. So we're not talking about very large anatomy, and so doing that again with freehand technique is going to be quite challenging, but being able to actually navigate it made it that much easier. And then when we go from the back, again, with such poor quality bone, the idea is how can we improve fixation both proximally and distally? And we did that by actually putting in 2 iliac screws on each side. And now in an adult patient, that's not a big deal, but when you have someone who's 9 years old and even small for her age, that becomes sort of problematic. And with poor bone quality, you don't have but one chance to do so. Being able to plan that out intraoperatively really allows for a smoother case. And at the end of the day, this patient did well, and I think that it was, at the hands of experience of the team in doing this, but also really augmented by the idea that navigation allows us to do this predictably and reliably. And for that reason, I really do think it helps the way we can treat our patients. So is it crutch or critical? It certainly adds some great benefits to our patients. So I definitely think that surgeons should be familiar with this in regards to the reliability, predictability, and planning. In my hands, I really think it shows great promise, especially in revision surgery, challenging dysplastic or dysmorphic anatomy, teaching, and perhaps in future standard of care. I think this is becoming more and more accepted, and I don't think that some of the unpredictability and unreliability of some freehand techniques is going to be acceptable as we move forward. It does have significant limitations, changing anatomy. When you talk about deformities that change as you actually do the surgery, I think navigation still trails in its ability to adapt to that. There are some things that we use insofar as using additional fiducials and so on to be able to re-register intraoperatively to make our imaging more accurate or the navigation more accurate as the deformity changes during surgery. But again, that's something that surgeons would need to just get more experience using it to mitigate some of these issues. However, I really do think it has good potential in us being able to help our patients even better in the future. So thank you for your time.
All right. Well, before we transition to some case presentations, we have some questions. Dr. Launer?
Steve, and maybe for Kane as well, if he's here. Do you think this is getting to a point in navigation and these technologies to the point where it's becoming standard of care? Where it's standard of care, and if we don't have it, can't do the case, or if you have it in your institution but the system's down, that the case should be canceled. Are we getting to a point where that's going to be required from a medical legal standpoint?
That's a great question, and I think we are slowly getting to that point. At first we think of it as being a crutch and, I don't need it to do the case. But now I think that, certain states, when you look at some of the suits that have gone out, and whether it could have been avoided with the use of technology such as navigation. I think that hospital systems, even though funding these, this equipment was shunned upon years ago, they might, for risk management reasons, might start to pony up to get that in.
Great talk, and my use of navigation and adaptation of it has been very similar to yours. I think I have a very similar question as Dr. Lahner, but I think I wanted to see do you think there's a kind of an obligation for us to preserve the art of freehand, like their portion of teaching the fellows in the next generation that art, and there's a fine balance where it should be done. So, because maybe for us, it's like riding a bicycle, and if we don't do it as much, we can come back when needed. It was very important for us when we went on a mission trip when the C-arm wasn't even working for half of the cases to get that done. So do we have an obligation to keep teaching that art to the next generation, or is it going to go away in 20, 30 years and no one's going to be doing it?
Yeah, absolutely. I think we have an obligation. By no means does this replace the surgeon, and that gets into the talk on robotics. Even when you're doing these cases with navigation, you're not just following the navigation. You have to follow what you know, and if you don't know how to do it on your own, you'll never be able to be the person to question whether that makes sense. There have been several times I've been in a case where I say, well, that just doesn't make sense. And then I go and I re-register, I go and I look at a fiducial, oh, well, that's why. And so if you don't understand how to do it on your own and do it freehand and you can't do it without, then it makes it dangerous. So certainly it can't be used as a crutch, because at the end of the day, the surgeon's doing the surgery and the surgeon's responsible for those results. And if you can't tell whether the machine is giving you information that is accurate or precise, then there's an issue. There will be an issue for sure.
That was a great talk. I had an interesting experience in that as a resident, we used navigation, which was 10 to 15 years ago, I guess now. And then going into fellowship, it was all freehand. And you don't have that feel when you've learned with navigation the whole way through. And I haven't used navigation since. And hearing all of these talks, I'll eventually take the plunge. But I do feel that people who've never developed that feel at some point in their training and their careers, they may not know what you know because you learned to do it freehand first, or what I had to learn, in my fellowship and then in my years of practice. There's a touch to it, and there's a sense that it's wrong. And if you're just looking at the screen, I worry if you have all of that.
No, absolutely. I think, as I said, I was a late adopter because I thought that the way I was doing it had good results, and why would I change? But then when you really start to dig into the technology, you realize there are so many things, there's so many nuances where it can help you. You know what I mean? And we talked about this during the break about how, the stress of the surgery shouldn't really come with instrumentation. The stress of the surgery should be with the planning and being ready for all the other things you might encounter. So this really does make that stress less, and it makes it more reliable, so you can start thinking about all the other things that you need to do in these complex patients. Thank you very much.